Dr. Mohammed, can you hear me? Dr. Mohammed, can you open the microphone? Can you hear us? I'm sorry, I was told that we were ready to begin. Maybe Dr. Mohammed is having some like troubleshooting right now, so we will double check right now. Yes, Doctor, can you hear us?
Yes, I can hear you. It's me, Mohammed Qasim.
Okay, so well, we will begin our webinar right now. Now that you can hear us very well, and well, I will begin now. So everyone is ready? Okay. So we're getting ready. Dr. Mohammed, I have a question for you, because right now our team, well, my team is telling me that, well, that you are the moderator. So I just want to confirm whether or not you are the moderator of the webinar.
Hello, hi, I'm Professor Abuzid, the moderator.
Yeah. Can you hear me?
Yeah, hi.
Yes.
I'm Professor the moderator.
Okay.
So can you hear me right now?
Yeah, I can hear you right now. Can you change the name of your Zoom?
Professor
they will change it for me. Okay, hold on.
Okay. Okay, we can start right now.
Well, thank you very much for everyone, and well, for being really patient today. Well, we are really happy to have you here, and well, we'll begin with this with our 9th webinar. So okay, welcome, ladies and gentlemen. My name is Gabriela, and I'm part of the International Marketing Department at Ezisurg Medical. It's a great pleasure to welcome you to the 9th episode of Bariatric Webinar Series. Our previous 8 episodes have been a great success. We've got a lot of positive feedback, which is also a huge motivation for us and organize more academic events. Today's topic is about bariatric surgery in COVID-19 area. This is a very important topic nowadays, because it's, well, right now the world has has been very influenced by the COVID-19. So we as a company, as a medical company, we want to take this topic very serious. So that's why we have invited you to discuss this topic today. And the first thing I would like to know is to introduce our speakers and the moderator for today. We have Professor Muhammad Abu Said from Egypt, who will be our moderator today. Then we have Professor Sendo Boras from Croatia. Later we have Professor Hilnik Alas from Belarus. I'm sorry if I'm not pronouncing the names correctly, but well, and lastly, we have Professor Giovanni Lesti from Italy and Dr. Marcelo Avalone from Italy as well. I would like to thank you, all of you, for taking your time and joining us in today's webinar. To thank you for sharing your valuable knowledge with us. For us, it's a great pleasure to have you here because you are an international group of experienced surgeons with a lot of experience, and we really appreciate you share your knowledge with us. It's also a great pleasure to provide a platform where you can discuss the most recent and most important topics in the bariatric field. I would also like to thank everyone here today because, well, we really appreciate your help. And I also want to wish you all a really great and successful webinar, and more important, a very educative session. And now I will to give the word to our moderator, Dr. Muhammad. Thank you very much for joining our webinar, and we are happy to have you here. And well, let's begin.
Hello, hi everyone, and it's really an honor to moderate this great webinar with the great speakers from Italy, from Croatia, and from Belarus. And I hope that it will be beneficial for our colleagues and our patients. As you know, that COVID is affecting our practice from start of the 2020 till now. And personally, I didn't stop my practice. I just had some extra precautions. And I would like to hear today from the well-experienced speakers today about their experience with the COVID era, and if the patient is having a benefit from having obesity surgery in the COVID era, and losing weight for obese patient, is it beneficial to the patient? And we'll start with Professor Janko Borash from Croatia, and he will speak to us about the prior surgery in COVID positive patients. Could it be protective or not? Please, Professor, start.
Can you see my screen?
Yes. Yes. Right. Yes. We see the screen, and right now.
So good afternoon. Yes, good afternoon, everyone. I'm Zdenko Boras. I'm a head of the bariatric unit in Croatia in a clinical hospital Osijek. And the topic of my talk today will be could prior bariatric surgery be protective for the patients that become COVID-19 positive? Firstly, I would like to thank Ezisurg company for organizing this webinar, and thank you for the nice introduction, Professor Abu Said. So I have no disclosure, but I want to say that all of us that are doing bariatric or metabolic surgery know that worldwide obesity in this COVID era in last 2 years are gained around 30%. So this is the bad thing that happened in the fast growing chronic disease of epidemia, basically, of obesity. With a global prevalence of almost 40%, we had a pandemic of COVID-19, and it has so far infected over 250 million people and killed over 5 million people worldwide, and also had influence on our practices, daily practices as bariatric surgeons. Connection between epidemic and pandemic is that obesity seems to increase the risk of both COVID-19 complications and also increase the mortality. So what really happens if the obese patient is infected with a COVID virus? COVID virus goes through the respiratory tract and stays in lungs for a while, then it spreads throughout the whole body, but mainly goes to the adipose tissue. And there the ACE2 expression is the highest in our body, and that's the main problem for the obese patients. Immune system for the COVID, for the obese patients is already pre-activated. It's a chronic inflammatory state. So interleukins and tumor necrosis factors are high already. And then we have the cytokine storm, or a viral shedding with the cytokine amplification that influence our obese patients. There are multiple pathways, and this is all theory because this is not proven still yet, but this is just a logical thinking that these pathways could go, like I said, through the lungs, because the obese patients have less of the forced expiratory volume and diaphragm contractility. Also, they have multiple comorbidities as a cardiorenal stress, high blood pressure, and diabetes. All of that on the one side will have impaired metabolic response. On the other side, we have this viral spread, viral shedding in the adipose tissue that's already been dysfunctional and it's already pre-regulated, and that all together combines the high severity from the COVID-19 infection for the obese patients. Role of the adipose tissue seems to be the most important because the ACE2 receptors, and we know that adipose tissue is independent endocrine organ. It's not just storage for the energy. It releases great amount of peptides or adipokines, and they already have pro-inflammatory actions. ACE2 receptor expression is the highest in adipose tissue, even higher expression than in the lungs. And unfortunately, COVID-19 virus has a high affinity for that receptor, and this is the entry in the host cells, and then it results in pathological changes. Like I said, obesity is an inflammatory state, and there's a clear association between obesity and the basal inflammatory status, because we know that patients have higher circulating interleukins and C-reactive protein levels. It's also pro-inflammatory with increased expression of cytokines and particularly adipokines. And obesity by itself is an independent risk factor for the development of the immune-mediated disease. Microthrombosis is also one of the possible pathways that we have witnessed in our obese patients, actually in all patients, but in obese patients maybe a little more, because not only the dysregulated inflammation, also the augmented coagulation and thrombotic accidents are happening in the ICU units. So in numerous patients that had acute respiratory distress syndrome, we witnessed DVTs and thrombocytopenias, renal failures, and disseminated actually intravascular coagulation in all the vessels. And the patients with the microthrombosis have more comorbidities, which is also logical, like hypertension, cardiovascular disease, and type 2 diabetes. So this is the study from Arthur Simonet and allies that showed that patients that required invasive mechanical ventilation are more prone to be obese. So they compared 124 patients, of which 85 had invasive mechanical ventilation, and we see that these patients had a higher BMI than the patients that did not have mechanical ventilation. Also, patients had a higher percentage of diabetes, hypertension, and dyslipidemia, but the BMI was also independent factor for putting those patients on the mechanical ventilation. So obesity, or this excess ectopic fat deposition, could be just a unifying risk factor among all other comorbidities for severe COVID-19 infection, reducing protective cardiorespiratory reserve, and also potentiating immune dysregulation. This is the study from the United States that showed the link between the rate of the hospitalized patients, ICU admissions, mechanical ventilation, and that so linked with the BMI. So we can see that all of these four graphs are showing as the BMI is getting higher, there's a higher rate of hospitalization, higher rate of ICU admissions, higher rate of ventilation, and of course, high rate of dead patients, unfortunately. So this is the paper that I read, and I put it as a basic of my topic for today. And this paper says that prior bariatric surgery in COVID-19 positive patients could be protective. This is also logical because all patients that will have bariatric surgery will probably lose some weight and diminish some of their comorbidities, and just by that, they will probably be COVID will be less severe. So we can see that patient that had surgery, bariatric surgery before they got infected, that's their number, and this is the control of the patients that still did not have a surgery but were candidates for the surgery. And we can see that there's almost a double percentage of intubations, ventilations, ECMO placements for the patients that did not have a surgery. Also, we can see that ICU stay is doubled, and unfortunately, there were double the deceased patients in the group that did not have bariatric surgery. So what do we know? In these last 2 years, we understood that if the obese patient got infected with a COVID virus, there will be multiple pathways of reaction, but will have probably higher risk of mortality and morbidity. First of all, the lungs will be the primary problem, and they will have exacerbated inflammation. Also, like I said, they will have a cytokine storm through the macrophage activation and a lot of adipose tissue, and the other pathway with the hypercoagulation, producing thrombosis and thrombocytopenia. We all know that bariatric surgery, and it's proven in many papers, that bariatric surgery improves respiratory mechanics, both obstructive and restrictive, together with the weight loss after the bariatric surgery. And that could be the explanation for the decreased need for the mechanical ventilation and severe COVID-19 infection. The other pathway, of course, is that bariatric surgery results in improvement in inflammatory markers with reduction in adipose tissue. In conclusion, patients with obesity have been disproportionately impacted by COVID-19 and have high risk of severe disease and death. Bariatric surgery improves respiratory and inflammatory factors that likely put this population at risk. The paper that I showed emphasized the importance of bariatric surgery as a protective factor against severe COVID-19 infection, and that in a high-risk population. With weight loss associated with bariatric surgery, there is improvement in inflammation, coagulation activation, and fibrinolysis, and also significant decrease in dead dimers and CRP activity as early as 12 months after the surgery. And several studies demonstrated lower levels of CRP were associated with less severe COVID-19 disease, and also if the interleukins are lower, decrease mortality from COVID-19. So to finish this presentation, I would say that bariatric surgery remains the most effective mechanism of the long-term weight loss and consequentially in overall reduction in adipose tissue. And this reduction of adipose tissue seems to be the main issue because it improves inflammation and the patients have better respiratory function. That could be the key mechanism related to the protective effect of the bariatric surgery in COVID-19 patients. Thank you for your.
Thank you, Professor Borash. Thank you very much. And I would like to ask you, when you saw your patients after the operation, I mean the last 2 years, patients who had already sleep or bypass in the last 5 years and came to you after the operation in the follow-up and told you that they had COVID infection. So do you see that the infection is less in these patients or more? I mean, in because we know that immunity affects the outcome of the patients.
Well, it's hard for me to say because I came back from UAE 2 years ago, just when the COVID outbreak in Croatia, and I only can talk about the patients that I did here. And there's only a few patients that I operated on in 2019, just before the COVID outbreak. And actually, we are making the study of these first 10 to 15 patients, and half of them were actually having the unfortunately infection. None of those patients were admitted to the hospital, and I can say that none of those patients were admitted to ICU. Although at the time of the COVID infection, they still did not lose that much of their excess weight, but they got rid of some of the comorbidities, like type 2 diabetes and hypertension. So for these 10 to 15 patients, I can say that bariatric surgery probably helped.
All right. Thank you very much, Professor Borash. If any of our honored speakers would like to ask any question, it would be nice. And I would like also to introduce our professor, our second speaker, Professor Giovanni Lesti from Italy, and he will have 2 presentations today. He will speak about the bariatric surgery in COVID era. Thank you, Professor Lesti, for being with us, and we are here to hear you.
Thank you.
Yes, please speak, Professor Lesti, please.
Okay, can you hear me?
Yes, right now we can hear you, and we can see your presentation right now. It's on our screen right now.
Okay. So it's my pleasure to participate in this webinar and present the difficulty in obesity surgery in Italy. It's very important what we have lived and learned in this pandemic, and to be ready to face a new pandemic more prepared. So this is the phase. In the first phase, the lockdown slowed the spread of the disease. It's very important. In second phase, the opening of the activity state by state. In the third phase, protect the population with vaccine administration. And I don't see the fourth. It's important to reveal our readiness for the next pandemic. So we have the early infection phase with mild symptoms as a fever, cough, myalgia, fatigue, sore throat, and headache. The second pulmonary phase, we have the respiratory failure with hypoxemia, tachypnea, shortness of breath. And the third phase, we have the ARDS, shock, multi-organ failure. The obesity is the first important point for the obesity, and after we have the age, lung disease, cardiovascular disease, diabetes. This is it. In Italy, the surges in COVID-19 pandemic, the elective surgery was very reduced, and to leave space to the emergency operation and the oncologic surgery. High number of infection, high rate of hospital and intensive care unit admission, and we have a high mortality rate. This terminate of the change during COVID-19 in the pandemic in the resident of Northern Italy. We have, regarding the food intake, no change in 43 patients, increased in 42% and decreased in 13%. Weight change, no change in 34% of patients, increase 1-2 kilogram only in 27, no weighting, and 1-2 kilogram loss in 16, and more than 3 kilogram in percent. Prioritization of the criteria of bariatric surgery during COVID-19. The threshold capacity of healthcare system and the fast and significant weight increase, worsening of metabolic parameter, onset of the diabetes and hypertension, psychological destabilization, and complication from previous bariatric surgery. In Italy, the number of intervention in the year 2019, the blue, had a decrease in August for vacation and reducing the bed in the hospital. In 2020, decreased in March, April, and May for pandemic, and in December for holiday. In 2021, the first months, the operation are over 800 for month. This is evolution COVID-19 in China. We see that we have the sleeve gastrectomy, 10,000 in 2019 and 14,000 in 2020. In Roux-en-Y gastric bypass, 2,000 in 2019 and 4,000. So the former FDA administration commissioner, Scott, he believed that the COVID pancreatic will soon be an endemic. Very important to move it on from pandemic to endemic. An endemic is an outbreak that always present in particular region, but for more manageable, like the common cold. This is going to become more of an endemism, where you just see sort of a persistent infection through the winter. So, COVID in the world, we must improve our hospital bed intensive cool and capacity to accommodate a large surge of patients. Thought public-private hospital preparedness for public health emergencies should be elevated as a function analogous to the director of natural intelligence. Establishment of national infection disease forecasting center is important. Even the important role of infection disease modeling in supporting public health decision making. We should increase our national capacity to treat infection disease. Modeling to support public health decision making by a national infection disease forecasting center. It would also provide decision support to public health agencies based on modeling and analytic results. It's important to reduce future burdens on our critical care system. We must also support our primary and community care compatibility to identify population and evaluate risk, detect cases early, and manage them at home or in the community more effectively. The development of vaccine for novel virus in months, not years. The state should lead the way by setting an ambitious goal of rapidly developing medical counter measures for novel and unknown threat in months, not years. So, right, the last one. Yeah, see. So, developing vaccine for novel virus month in no year. The state should lead the way by setting an ambitious goal of repeatedly developing medical content issued for novel.
Professor, we can't hear your voice right now. I think you lost connection, maybe. Professor Letton, can you check your connection, please? So please, can you hear me? Professor Marcello, can you hear me, please?
Yes, of course.
Yes.
Good morning.
So, yeah, hi again. So can I introduce you, Professor Marcello Avallone from Italy, who will speak to us about COVID-19 and bariatric surgery, what to do. You are more than welcome to start.
Yes, of course. I share the screen. You see my screen?
Yes, yes, right now we see your screen. You can start, please.
Oh, perfect. So, COVID-19 and bariatric surgery, what to do? So we passed a terrible period, a terrible and strange period, in my opinion. We passed through a pandemic virus of COVID-19 that infected all over the world. It's a very strange and particular case. So, for example, I have never seen cities like my city, like Rome, desertic. I have never seen intensive care unit full, completely full. And I have never seen pictures like these. So, but like a singer said, show must go on. So in my opinion, we have a triangle. We have the bariatric surgeon, our obese patient that, like my colleague told before, we assisted and increased the curve of obesity during this period because of many patients are depressed. They doesn't go out, so they need to take food to increase their level of serotonin. And we have our enemy, COVID-19. So what to do? Professor Lesti told before, at the beginning of this infection, we stopped bariatric surgery. We can perform just oncological and emergency surgery. But after that, we decided to restart bariatric surgery because obesity increased like other pathologies. So it was not correct to stop bariatric surgery. But we had, I talk for me, for example, I had a lot of questions because when you perform a bariatric surgery, you maybe you need intensive care unit, and if intensive care unit are full, what to do? So I try to answer to this question. So it's correct to perform a bariatric surgery to prevent a COVID-19 infection like we see before. Yes, it's correct, and I will try to show other evidence-based medicine. And when perform a bariatric procedure after a COVID-19 infection, it's correct to perform or not, and when to perform, in all patients or just in some patient that hadn't a gravity infection of COVID-19. So the first study we already saw it, if I remember correctly, and I go fast. We had 620 cases, a group of bariatric cases, a group of bariatric control, and this study shows, like Boras told us, a significant p-value in ventilation, emergency access, and length of hospital stay, comparing bariatric controls to bariatric cases. So what I can confirm is, of course, bariatric surgery is a strong protective factor against COVID-19. This Italian study is based on 2,145 patients. They underwent all previous bariatric surgery, so it's a retrospective study. 231 showed symptoms like flu, so similar to flu. But between these 231 patients, just 26 were tested. Just 26 because at the beginning we had not test for all patients, just a patient in which it was retained necessary to perform a COVID-19 test. So 13 were positive, and between these 13 patients, just 2 need intensive care unit recovery. This is in this table you can see the explanation. Of course, like my colleague told before, when you perform a bariatric procedure, the majority of comorbidities are solved. You can see in blue before surgery, in red after surgery, and like you can see, hypertension, diabetes, GERD, sleep apnea syndrome are almost solved. And in some cases, we have no comorbidities. So we can confirm in this second study that prior bariatric surgery is a protective factor against COVID-19. This third study talk about association of prior metabolic and bariatric surgery with severity of coronavirus disease in patients with obesity. They found 4,365 severe COVID-19 infection just 33 had previous metabolic surgery, and these 33 cases were matched with 330 control group. What they found is shown in this table. In black, you can fix the control group, 330 patients. In white, the patient that underwent prior metabolic surgery. So we can what we can see is that a comparing with hospital admission between two groups, just the 18% of patients that underwent a prior metabolic surgery need hospital stay. And between these patients, we had 0 intensive care unit admission, 0 mechanical ventilation, 0 dialysis, and 0 death. So we can another time confirm that bariatric surgery is a protective factor against COVID-19. So the first round is win by bariatric surgery and bariatric surgeons. We can pass to the second answer. Bariatric surgery, when and if is correct to perform bariatric surgery after an infection of COVID-19. This study enrolled 8 centers in 5 countries, and they tried to find if there are more COVID-19 complications in patients that were underwent bariatric surgery after COVID-19 complication. Between these patients, 35 were analyzed. Here you can check demographic data. So the majority were female, of course, at least in my country, the majority of obesity is female. A BMI, a mean BMI of 44, and they performed these procedures. So sleeve gastrectomy, Roux-en-Y, SADI, MGB, and 1 case of gastric band removal. Here you can check about these cases, the mean time between COVID-19 infection and bariatric surgery. You can find that in 12 patients is between 3 and 6 weeks. In other 12 patients is in 13 and 26 weeks. So there is a variety of time between surgery and between COVID-19 infection and COVID-19 and bariatric surgery. But the important thing is that the analysis of these patients showed not more complication after bariatric surgery if these patients were affected before by COVID-19. So these symptoms are more common after bariatric surgery, so no more complication. And in this article, the authors say that if it's correct, wait 4 weeks after COVID-19 infection to perform a bariatric surgery. Other authors answer to this article with a criticism and reporting 2 cases report. I spent some word to say to you 1 case report. They had a 44-year-old female with a body mass index of 47. She was candidate to bariatric surgery, but she stopped because she was positive. She solved her pathology, her COVID-19 infection. They so past 2 months after COVID-19 infection, and she was candidated another time to bariatric surgery, but they decided to perform before bariatric surgery a CT scan, and this CT scan found ground glass opacities. So they performed ACT with ventilation perfusion scintigraphy, and this CT showed multiple areas of hypoperfusion bilaterally with sign of thromboembolism, like my colleague told before. So they concluded that every patient in every patient depend what COVID-19 do. So it's necessary a CT scan before every bariatric procedure, and I say every surgery, if patient is affected from COVID-19, and 4 weeks can't be enough. I report the last cases. This case happened in Italy, is not publicated. 55 years old female smoker, but I say smoker, but just 3-4 cigarettes per day, so no more. She had COVID-19 infection one month before bariatric surgery. She solves completely. She performed sleeve gastrectomy, a not complicated sleeve gastrectomy, just 40 minutes surgery, so not intraoperative or postoperative complication. But after 2 days, she showed bilateral pneumonia, not related to COVID-19. The test was negative. So she need 25 days hospital stay and antibiotic therapy to solve the infection. So take home message, like I told before, in my opinion, prior bariatric surgery is protective factor against COVID-19. 4 weeks is not enough after COVID-19 infection in general, and CT angiography is necessary in patients with previous COVID-19 infection before you can perform a bariatric procedure. Thank you very much.
Thank you very much, Dr. Marcello, and I would like us to engage all to speak about this, because we need your experience, everyone, before we complete our presentations. I need you to tell us in each of your centers, what is the gap between the COVID infection and the operation in your experience. Please, Professor Alexi, tell us in your institution, in your hospital, what is the gap between the patient infection and the operation? Professor Alexi, Helnik Alexi.
Yeah, I can hear you.
Yes. So, in your experience, what is the interval between the operation, between previous COVID infection and the operation?
No, we usually wait that the patient so we don't do big and does bariatric surgery in patient with say with lung disease on this disease. No patient with lung disease we can make the operation.
Yeah. Okay, Dr. Boras, if patient don't have right now a lung disease, but he has a previous infection of COVID, So, Professor Burash, can you tell us how is the time between the infection and the operation, in your opinion?
Well, I don't see that there is need to be a rush for that. I would wait for a few months. We still don't have that kind of patients here, in my experience. We have one patient that was scheduled for the surgery and got infected, and it's more than 6 months from now, but he's not feeling well. So it depends from the patient status, right? If it's a younger patient with no comorbidities, I think you can do a surgery maybe a little bit earlier. But if it's the patient with a lot of comorbidities and it's still not recovering well, and a CT of the chest or just a plain radiography shows that the lungs are still not expanded totally, I don't see the reason for the rush.
Yeah, but if the lungs are good, so you can proceed even after 1 month. I mean, if the CT scan, the lung CT scan is good, so you can proceed after 1 month from
Yes.
infection, or you can do more. Yeah, all right.
I would wait at least for example, for 3 months. I would not do it earlier.
All right. Dr. Marcello, your opinion, your
Yes,
experience?
my opinion, as I told before, is the same that told Boras. I think that every case is apart. So if the patient is very young, there is no comorbidities and not too much high body mass index, you can perform bariatric surgery after 2 or 3 months after COVID-19 infection. If infection, it didn't require the ventilation, hospital stay, or something similar. If not, you have to perform a CT scan, lung evaluation, and etc. etc. This is my opinion.
All right. And what about vaccination? We didn't speak about the after vaccine. How long do you wait till you do the operation after vaccination? I mean that most of my patients will call me and tell me I will have the vaccine. When should I take the operation after the vaccine? So in your opinion, every one of you, please share your opinion after vaccination. And please, if you know the kind of vaccine in your country, please share with us.
Yes, many patients asked me how many days I have to wait. Normally I told to this patient it's necessary that you wait 15-20 days and then we can perform surgery. I just expected the first reaction that have a vaccine and then I perform surgery. Yeah.
So what about you, Dr. Borash?
Yeah, it's the same. It's actually ASMBS got the guidelines, and I would agree with Dr. Avalon that after 2 weeks, if there's no reaction to the vaccine, you can do the surgery.
Okay, great. So our next speaker is Dr. Helnik Alexei from Belarus, and he will speak to us about bariatric surgery in the context of COVID-19 infection in Minsk. His center is for surgery.
Okay. Can you hear me?
Professor Alexei, can you hear us?
Yes. What about you? Can you hear me?
Yes,
Yeah,
we can hear you.
I hear correct.
Okay. Hello, dear friends, dear colleagues. I'm glad to take part in such interesting webinar, and I want to show my opinion about the optimal time after the COVID infection, when to do the operation. As for me, it's good to wait 2 or 3 months, like all the speakers said. And what about the vaccination? We are waiting 3 weeks out after the vaccination. Now my presentation about our work with COVID-19 infection, bariatric surgery in this problem in our Minsk Center of Surgery, Transplantology and Hematology. Our center providing high-tech care of patients with surgical hematological pathology. We perform organ transplantations, liver, kidney, pancreas, lungs. We are performing plastic and microsurgery. We are high quality center of hepatobiliary surgery, and last 7 years we are working as a bariatric surgery center. We performed about 100 surgeries weekly, but it's not only bariatric surgery, it's all surgeons. But we are like a clean center because we don't work with COVID patients. But it's will be our happiness. But one of our ICU have been allocated to assist pregnant women, like the extracorporeal membrane oxygenation center. And we have one ICU unit for hematological patients with COVID. To our therapeutics department in the hematology and pulmonology are also accepted like COVID centers. Our department of surgery, it's 60 places. Pre-COVID, we work like routine emergency care, but now we are working only like an emergency surgical center. All patients undergo rapid testing for COVID in the emergency room and PCR testing during hospitalization. But 1% of hospitalized patients had a COVID infection. Bariatric surgery in our center we began in 2014. We operated about 500 patients from this time, and more than 150 patients performed during the COVID infection epidemic. Our typical patients, it's a female, middle age, with high BMI, about 43, and metabolic syndrome. Here's the type of operations performed in our center. We made for patients gastric banding, sleeve resection, classic or mini gastric bypass, gastric plication, but we don't like this operation, and that's why we perform our original method, the resection of gastric fundus and the application of its body. Preoperative examination, it's blood tests, ECG, therapeutics conclusion, esophageal gastroduodenoscopy, gynecologist for the woman, endocrinologist, fluorography, polysomnography for all the patients, preliminary examination of anesthesiologists with all the examinations. Is COVID-19 a call of bariatric surgeon? It's a question which we asked ourselves when this pandemic was begin. And there are three problems we have. It's the safety of our patients, what to do if the patient have COVID, and what to do with the complication, COVID complication and other complications. Security. Before the advent of vaccines, PCR test performed 3 days before hospitalization and on the day of admission to the hospital. All the patients were isolated in the single room. We minimized the contact with others, with the visitors, and the contact with the staff was in a protective equipment of staff and of patient. Patient communicate with us only in respirator. Non-contacts with visitors, but sometimes it's very difficult to do it. And now operations during the increase of infections. Now we are in the fourth wave of COVID in our country. But first and second wave, where there were no vaccines in Belarus, we stopped our bariatric surgery. When we have vaccines in our country, it was the rule for our patients. They must be vaccinated, full course of vaccinations, and 6 months they need their revaccination. What to do with the patient if we think that they have a COVID? The appearance of fever, respiratory disorders, myalgia, urgent PCR test, and the patient will be in isolation. If we found the COVID infection, transfer to the intensive care unit, prone position, and oxygen for these patients. We have 5 complications during these 2 years, 3.3%. We have 1 bleeding, which and we made the laparoscopy and hemostasis, 2 leakage from the staple line, and it was a terrible situation because every bariatric surgeon knows that it's not good for the patient, but they are alive. And 2 patients have COVID infections in postoperative period, and I wanted to show you these 2 cases, case reports. What's going on? The first one, it was a woman, 58 years old, suffered from mini gastric bypass. She had uncontrolled weight loss. Revision revert operation has been performed. We found an anomaly of small bowel. It was total weight was about 305 meters. After the operation, COVID developed. The condition deteriorated sharply. Respiratory failure required ventilation. After 3 weeks, the patient died. And when we made the investigation, we found that the patient was in contact with her husband, who was ill in a mild form. Vaccination at the time of surgery was not carried out. And another case, patient 53 years old with BMI 42. We performed him mini gastric bypass. In the postoperative period, on the 4th day, the temperature was up to 37.6 degrees. Computer tomography of abdomen didn't reveal any problems in the area of operation. Emergency PCR test was performed and there was a positive result. Treatment in COVID hospital, discharged with recovery. The patient underwent a full course of vaccination but didn't comply with the regime of minimizing contact with visitors. He thinks that he is fully protected by the vaccine. My conclusions. Obesity patients are the special category who may have more severe COVID infection. Vaccination in bariatric patients is a prerequisite for considering the possibility of their intervention. Bariatric surgery can be performed in conditionally clean surgical centers in vaccination patients with in compliance with all safety measures. That's all. Thank you.
Thank you very much, Professor Alexey, and thank you for sharing your experience with us. And before moving to the last presentation of Professor Lesti, I would like to ask you if you had seen a patient with COVID presentation that had prior surgery like sleeve or bypass and had reduced immunity after the operation, because we know that with patient with bariatric surgery, if he has a twist, if he has a chronic kink or a narrowing, he would have some decreased immunity because he can't eat normal healthy food, and he usually takes like sugary or a non-healthy food. We can see this usually in patients with kinks or twists. So in your center or other surgeons patients, did you see patients with reduced immunity after the operation, and did this affect the outcome of COVID infection in these kind of patients? It's up to you. Anyone, if any of you had experience with these kind of low immunity patients, please share with us.
About the COVID infection of post-operative period, we have some patients, about 20 bariatric patients who had a COVID infection in 1-3 years after the operation. All of them were not hospitalized into the intensive care units. 3 of them were in pulmonary units, but there were no dead patients in this group of our patients. There were no dead patients.
So, Dr. Marcello, did you see patients with low immunity after the bariatric procedures?
Sorry, can you repeat?
Yes, I mean that some patients after procedures, bariatric procedures, especially if they have long limb MGD or kinked or narrowed sleeve, they have low immunity. They come and say that they have repeated infections and repeated admission for multiple infections. So did you see patients with these kind of or these criteria or this affection and affected by COVID, and what was the outcome of these kinds of patients?
No, fortunately, I have never seen this kind of patients. So fortunately, everything was okay. So yes, there is no trouble like this. Yes.
Dr. Burash, did you see any kind of patient after the bariatric procedure?
Actually, no, because like I said before, we are very young and new program, and I still don't have patients. And in Croatia, the bariatric surgery was actually not performed for like last 10 years, and I don't have any patients from other colleagues or from other centers that are referring. So I do mostly primary cases, right?
So what we can say that like most of the if not all of the bariatric patients who had surgery before will benefit from the bariatric surgery. Okay, the last presentation from Professor Lesti. He will speak to us about the 10 years experience. Professor Lesti, please say your last presentation. I don't have the complete title, so please give us your last presentation, Professor Lesti. It's technical metabolic results of 953 patients, right? Yes, Professor Lesti, you can hear you.
Can you have me?
Yes.
Yes, you are already here, and we can see you and hear you. Please share your screen with the last presentation, please.
Okay, thank you. So I'm very happy to share with the panel this my procedure. It's more important for me your consideration. Okay. I think that the gastric bypass made in 1966, the stomach cannot be explored.
Please share your screen, please. Can you share your presentation, Dr. Lesti, Professor Lesti, please? Still, we don't have your presentation on the screen.
You don't have?
Yes, it's starting
Can
right
we
now.
try again?
Yes, please start your presentation.
Can you see now the presentation?
Yes, right now. Yes. Right now, we can see your presentation.
Oh, okay. So, I want to show the result in 953 patients at 10 years revision. So, I said the stomach cannot be explored in the normal gastric bypass, and the patient cannot perform a diagnostic and the operative gastroscopy. Sorry. I think that in the era of operative endoscopy, this is a real limitation that it's not acceptable. So what I did, but you see, my gastric bypass, we have a pouch 6 centimeters long and 2 centimeters large, and close with this device that I will, this device made by the, with the APTFE. The alimentary limb and the biliary limb usually are 130 centimeters. And when the BMI is less than 45, we have 120 and biliary limb and 20 the alimentary limb. Okay. They also the vision of the operation. We see this is the task, and I like to close the anastomosis with this ring of omentum. Okay. This model, after my model of Roux-en-Y gastric bypass, the following result can be observed with important metabolic effect. The gastric restriction leading to an early satiety and decreasing the volume of the meal. Resection of the fundus of the stomach leading to a reduction in the secretion of ghrelin and subsequent anorexic effect. Faster arrival of nutrient to the distal intestine in order to stimulate the release of PYY and GLP-1, which lead to decrease food intake and improve glucose tolerance. This is the idea of Rubino and Camin. All these rules are presented in my model of reversible gastric bypass, with last revision in 2010. Okay, this is the position of the trocars. This is the patient the day after, take the X-ray, show the passage barium directly to the alimentary. Nothing goes through the stomach, the excluded stomach. The gastroscopy show the anastomosis between the pouch and the alimentary limb, and to the close, we see the close of passage to the stomach. This photo shows the compatible of the PTFE with the intestinal tissue. This is very important. And we had to remove in a large smoker, the 4th month of pregnancy, was suffering from an ulcer of the gastrojejunal anastomosis, totally occluding the passage of food. The patient had a birth 4 months later. The removal of the band was very easy And this shows how the APTFA is compatible with the tissue. We have done 953 patients, 587 female, 348 male. The BMI 12% MI between 35 and 40, 80% 40 and 50, 8% between 50 and 60. This is our follow-up. At 1 year, we had the exit weight loss of 74, 2 years follow-up, 820 patients with 73, 3 years follow-up with 691 patients, 3.6, 5-year follow-up, 400 patients with 71, 7-year follow-up with 67, and 10-year follow-up, 104 patients with the same excess weight loss. Comorbidity resolution at 5 years, we had the hypertension, 70% resolution at 26 improvement. Dyslipidemia cured 84% resolution, 15% improved. Diabetes 78 resolution and 21 improved. Causes 60% resolution and 39% improved. Depression improved. We have no resolution, but improved in 86% of patients. The major complication was no mortality, 6 leaks, bleeding in the reoperation of the patient, 5, 12 ulcer in heavy smoker, 6 ulcer in non-heavy smoker, 5 internal hernia that need the reoperation of the patient, no structure. Now, the main point of this banded procedure is the device, because the device should have such elasticity to gently close the passage from the pouch to the remnant stomach of the solid and liquid food. At the same time, it should not allow any passage of the bite from the remnant stomach to the pouch. This is very, very important. However, it should permit the passage not only of the diagnostic 5mm endoscope, but also the operative endoscope, means 12mm. Now, we have done more than 1,000 patients with APTFA, but the main problem is that the APTFA is very compatible with tissue, but the closer depend on the surgeon. And I think that the technique that required the surgeon behavior cannot work. This is new device that I've created. Is a dual component band because it's made by a silicone strip inside the tube of EPTFA 4 cm long. The two materials are fixed at the end. The EPTFA assumes an accordion shape. The silicone strip has 3 measures, 5, 6, and 7 centimeters. So when the device is closed, the device is able to totally close the passage of the food from the gastric pouch to the remnant stomach. this is a experience of abundant gastric bypass. Does it make a difference? This is the William Howard and Christian Martin in 2012. He said that it's clear to us that there are big advantages in using a restrictive device for the gastric outlet in gastric bypass. And we place ring in all our bypass patients. However, most surgeons are not willing to use it, probably because it involves a longer duration of surgery or an increased cost, or because they are afraid to use a foreign material that could migraine or slip. Now, with the development of new implant especially designed for this particular purpose, it will be easier to popularize the laparoscopic band technique. So it's also very important to take in consideration that a lot of surgeons in the world are bending gastric bypass, sleeve gastrectomy, and mini gastric bypass. This model of ring can be adaptable to any surgical procedure, only changing the measure of the elasticity of the silicone strip. Thank you. Do you hear? Do you hear?
Dr. Mohammed, can you hear us?
Yes, sorry, I lost connection.
Okay, Professor.
So, Professor Lesti, thank you for very nice presentation. And can we ask you, did you see any benefit over the Roux-en-Y gastric bypass or the mini gastric bypass in your study? And if you can do in the future a randomized controlled study to see the difference and if it's really beneficial to do your technique over the other gold standard technique like Roux-en-Y or the newer one anastomosis or MGB, the mini gastric bypass?
Okay, I think that the results are a little better because I think it's very important, the fundectomy. No, for just we did this. I did it so short, but we did in the first 50 cases. We measured the ghrelin. At the ghrelin for 1 year, it was very low. This I think this is important. But the other important thing is that I couldn't accept that the patient have the stomach in the abdomen without any possibility to do a gastroscopy. No, this my idea came up only because I thought that it's not possible that the patient cannot do a gastroscopy during the life. This is and also regarding the length of the alimentary limb, a biliary limb, I really think that it's very important that the food should arrive as soon as possible in the ileum, because we have a lot of hormone that increase the weight loss, but increase also the pressure, and it's very important modification of the hormone play.
Yeah, and what about the passage of the endoscopy? You said that it's very easy to do a endoscopy. You mean that when you inflate the pouch with the air, then you can introduce your endoscopy easily?
Sorry.
How can you introduce your endoscopy? You only depend on inflation of the pouch with air to introduce your endoscopy if you need to do gastroscopy?
No, we do the endoscopy without any problem, and because we put the air when you are in the stomach, no in the pouch. This is important. But we have done more than 1,000 just with the strip of APTFE. And this is very limited because the APTFE, it's not elastic. It's not elastic. So this depends on the surgeon. And this is no good thing. Now, with this device, we have done 12 patients, and we have the possibility to do the exploration of the stomach without any problem. What's happened in the operation done with of the APTFE, that when the patient lose a lot of weight, the passage can be little more, and this is the problem. But with this combination of silicone and APTFE, we have the elasticity of silicone and the compatibility of the APTFE. And we had in over 1,000 patients only 2 migration of APTFE, just 2, that we remove by gastroscopy. The difference is very important because the PTFE, it's what you say, close with high tension, but the silicone, it's very important because it's elastic. And when you do gastroscopy, you don't have any problem because in our patient, we are over 1,000 now. The 5mm endoscope pass, and we have no problem. But sometimes the 12mm, so the operator gastroscopy, it's not able to move into the stomach, and it's a limitation. But with this new device, I think we are over the possibility to do every gastrectomy with 5 and 12mm gastroscope. So you can do the operative gastroscopy.
Okay, do we have any questions from our honor speakers? Do you have any question to Dr. Lesti about his procedure?
I have no question because sometimes I saw this procedure and I'm interested in, and I want to confirm what Professor Lesti said. Yes, maybe many surgeons are afraid by the erosion, the probably risk of erosion of these part, like the gastric band. I know that erosion are very, very rare in a gastric band, but maybe some surgeons have afraid of erosion or slippage of this ring, and other surgeons want to go so fast. So maybe this procedure is a little bit longer. I think little bit, not so much longer. Roux-en-Y gastric bypass classic. So maybe these are the reason, because it's a very powerful procedure, because of you can explore the stomach. For example, there is a patient that I have, and maybe I will perform this procedure because this is a celiac patient with a very strong esophagitis class C. So he have very strong reflux disease, resistant to any kind of therapy, PPI therapy. And I think that the modified Roux-en-Y gastric bypass with less the modification, it's very good, because you can explore the remnant stomach in a celiac patient, and you can correct the reflux, the reflux disease.
Okay,
So
Dr.
we can
Bourash,
see.
do you have any comment, Dr. Bourash, Dr. Alexi?
No comment. Thank you, Dr. Professor Leslie, for presenting this very nice surgical procedure with very good results. Obviously, I'm not doing it that way, but that doesn't mean that it's not a great procedure, right?
Dr. Alexi?
I'd like to thanks Professor Leslie for this nice presentation, and I want to say to Professor Avalon, you are a lucky man, because we have a lot of gastric band erosions which performed in our center or in other centers. By myself, I operated about 20 erosions of gastric band, and sometimes it's not an easy operation. Thank you.
Thank you, Professor Leslie, for this nice presentation, last presentation, and thank you all our other speakers today for the very, very nice presentation. And returning to our main topic today, COVID and bariatric surgery, I think we concluded yet today that COVID is very, very, very risky disease all over the world. Bariatric surgery protects the patients from COVID. I think we all agree right now that bariatric surgery is very, very beneficial for the patients, especially morbid obese with diabetes and hypertension. Now we know that COVID in diabetic obese patients is very serious illness. And I think we are all helping patients when we do bariatric surgery for them. We concluded today that we have to take extra cautious measures for our patients in this area to protect them from getting COVID infection during or after the operation, especially in the first month. We agree today that it's better and safer for a patient to have the operation at least 3 months after the COVID infection. We agree that it's at least 3 weeks after the vaccination to have the operation. I think this is our conclusion for today. Thank you again, Ezisurg, for this very, very beneficial meeting and webinar. And please, if you have last word, just share it with us. Please, your mic, please. Your mic. Open your mic, please.
Okay, thank you. Thank you very much for everyone. Thank you for your contribution. Well, actually, yes, this is a very important topic, like bariatric surgery in COVID-19 area right now is a very hot topic, well, all over the world. And well, we also hope that this situation ends very soon. And well, one more time, I'm talking on behalf of Ezisurg Medical. We really want to say thank you to all of you for your contribution today. And well, I hope that, well, we can keep in touch, and once the pandemic ends, we can all meet together, maybe next year in some events in Europe or the Middle East. We like the whole team, the whole marketing and sales team, we are also, we really appreciate you help us to promote this academic webinar that we are holding. So, well, this is all, and well, we hope we can meet again. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Have a nice day.
Have a nice day.
Bye-bye.